I'm really excited today, and I actually got a preliminary discussion of some of this over lunch. We had an early lunch. But Dr. Heckman is one of Canada's very few, far too few geriatricians, and is bringing to our presentation today, but also to the field, some really exciting ideas about chronic care management, interprofessional education, and has a really diverse background both in engineering and in medicine and geriatric medicine, so there's a lot to offer. He holds the Schlegel Research Chair in Geriatric Medicine, and there's an exciting new center at the University of Waterloo, which maybe you can talk a little bit about, because it's cutting edge gold standard of care and long-term care environments, and seems to be a retirement home that really integrates research, practice, teaching, and fabulous service delivery. Hey, thank you so much for coming today.
Can you hear me okay? All right. Yeah, I can talk about the RIA in a little while, but thank you for having me here. And I never started my career and thinking I'd end up here talking about healthcare systems, but in many ways I trained as an engineer and then went into medicine, and a lot of the solutions that we need to think about in healthcare really are engineering, system engineering ones, because we've gotten too far away from the person, and we're too siloed, as you'll see, and we haven't really thought through what the issue is today compared to when we designed Medicare in the 1960s. In the 1960s, or even before in Saskatchewan, when Medicare was thought about, it was because if you were a farmer or a worker and you had an injury at work, you would have to go bankrupt in order to get your arm fixed or your leg fixed so you could go back to the farm. And really the healthcare system was designed around acute care hospitals for injuries or illnesses that were sudden and episodic, and that was fine back then. But one of the great successes of Canada, and I guess a lot of the Western countries, is we're living older. And that's something to celebrate. I don't think it's a tsunami or a disaster. I mean, this is a good thing. But it's changed the complexion of what conditions people have that affect their health. But the system hasn't changed to deal with it. So, as I said, I do a lot of geriatric medicine. I specialize in cardiac disease specifically, so you'll get a few cardiac disease references. But I've also been working with our local health integration network about how to reshape the system. It is a thankless job. I mean, it's pretty hard because we're trying to herd cats that have been working in the same way since 1950, and we have to change the way people think. I forgot to fill that in, but I have no conflicts of interest related to this talk. So I'm going to talk about a story that comes from a grad student's work. Like I said, I'm interested in heart failure, and heart failure is common. About 20% of people over the age of 80 will develop heart failure. And it's a very relatively manageable condition. You can pick up when people are starting to get sicker from it, intervene and keep them out of hospital. But to do that, you have to be really slick at assessing the person, the physical exam and the story. And one of the key things you want to look at is the jugular vein. So, this woman has the oxygen thing sign, but that's her jugular vein. And if you look around, hopefully you will not see people's jugular veins that easily. That means that the body is overflowing with fluid. There's too much fluid. And that fluid is also in this person's lungs, in their belly, in their legs, and they have trouble breathing. So this is an easy neck to look at. Most necks are hard to look at, and then when the disease is mild, it's even harder to pick it up. And family physicians and other physicians who don't do this on a regular basis find this really hard. So in Waterloo, there's this new startup company, and they've developed a little nice doohickey called, it's called the Venus 1000. I have no idea why they called it that. But the bottom line is you have a little heat sensing probe that you put on the person's neck, and it gives you the height of the jugular vein. And it's been demonstrated to work quite well and be very efficient. And we said, you know, why don't we go to primary care and long-term care and see what they think. You know, if they think this is useful, maybe we can start using it there. So we did some focus groups. So I won't go through the whole thing, but we interviewed physicians and nurses in nursing homes and in primary care. And the bottom line is they all admitted that they couldn't see a jugular vein if their life depended on it, unless it was so prominent that it was obvious, which it isn't most of the time. So they said, yeah, we're not good at it. And then we said, what do you think about this device? We showed them, we trained them on it, we showed how it works. It was fairly simple. And the nursing home doctors said, this is great. Their only concern was, as long as I know the nurses are doing it right. So we checked. We did a reliability study, and yes, the nurses do it right. And the nurses in long-term care said, this is great. That way we can assess that resident and we don't have to send them to the emerge. In primary care, the nurses said, well, whatever the doctor says. And the doctor said, I'm going to send them to emerge. So, same training, nurses, family docs, same disease, but completely different responses depending on the sector they work in. So that was interesting. So let's talk about the patient today, the older person, and what do we need to fix? And everyone's going to talk about time and money. The budget is such that there is no time and money, but it's always there as I'm not going to talk about it, but it's one of those things people talk about. But as you'll see, I don't think we need more time and money, we need more thought. So this is what the average 80-year-old person that uses the hospital in Canada looked like in 2012, 2013. This is data that is collected automatically on anyone who shows up in the emergency or the hospital, and it gets sent to the Canadian Institutes for Health Information. So these are the top 10 conditions. COPD, which is basically emphysema and chronic bronchitis, and heart failure are neck and neck. Then pneumonias, then bladder infection. This is mainly atrial fibrillation and irregular heartbeat that causes a lot of symptoms. This one is a funny one, general signs and symptoms, which to me means this is frail seniors. And frail seniors often, having not read the textbooks, will present with things like a fall, and in fact they have pneumonia, or confusion, and they have heart failure. Dementia, not that a common reason to be admitted to hospital, but it's present in so many people. This is dehydration from Norwalk viruses that give you diarrhea, heart attacks, and hip fractures. Now this cost is a bit underestimated because this does not include the rehab and the home care. But look at the number of cases, look at the length of stay, and look at the cost. So 22,401 patients with COPD at $7,500 a pop. Very expensive. But this is not individuals. Most of these folks, a person with emphysema, they have heart failure and they presented with a fall. So the way that we keep information does not tell the whole story. We'll talk about that. So multimorbidity means people who have more than one chronic illness usually. And so as you get older, you're more likely to have more than one chronic illness. And like my colleague Samir Sinha says, it's wear and tear. And the fact is we are surviving longer, which is a good thing, but we do accumulate illnesses, arthritis, heart disease, lung disease, cancers. And so if you hit the age of 80, you have a 40% chance of having 3 or more chronic illnesses. Now, the impact is very interesting. And so there's lots of data that says the more chronic illnesses you have, the more likely you are to be disabled. Doesn't mean you're more likely to die, though. So a person with 4 chronic illnesses may not be more likely to die than a person with 2, which is interesting and a bit counterintuitive. So the most interesting study I found was in Scandinavia, and they followed people who were, on average, 84 years old, and they looked at 2 things. They looked at death, and they looked at disability or functional decline, based on the number of chronic illnesses. And as you can see, If you have one or more chronic disease, your mortality rate is about double compared to if you never had a chronic illness, but it's pretty flat. But disability increases the more chronic illnesses you've got. And this is kind of how it works. And it's a very interesting relationship. So they looked at the risk of functional decline and the risk of death. And so this is the reference. You don't have any chronic illnesses and you don't have any disabilities, so that's your baseline risk. We call it the risk of 1. If you have chronic illnesses but no disability, the risk of death has gone up, the risk of disability has gone up a little bit, but not significantly. If you have multiple chronic illnesses but no disability, disability's gone up a little bit, death hasn't changed. So disability is important. Or multimorbidity is important, at least in terms of functional decline, but not death. Now let's look at, you've got a single illness with no disability, you have a single illness with disability. Your risk of further disability hasn't changed, but your risk of death goes up a lot. So the number of chronic illnesses is not related to death, but disability is. And if you have one chronic illness with disability versus multiple chronic illnesses with disability, then it's really bad. So it's not something you'd expect. Disability seems to be an important mediator here. So you can have lots of chronic illnesses, but you might be okay. I mean, we all probably know people who are fairly well, and they might be 70 or 80 years old, they might have diabetes and high blood pressure, maybe had a heart attack 5 years ago, but you wouldn't know it because they're out golfing. So disability also increases with age. The risk of disability goes up with age. It's not universal, but it's common. So basic activities include dressing and bathing and feeding. Instrumental activities means taking your pills, making meals, driving. So as we get older, about a quarter of us will have a basic ADL disability. About a half of us will have an instrumental ADL disability. So it's also more common with age. But is there something else going on? And that's where geriatrics becomes pretty interesting. We have these geriatric conditions, these geriatric syndromes. And in the Chi-High data, it's these general symptoms, right, that don't fit into a neat medical box. So hearing impairment, chronic dizziness, urinary incontinence. Very common, but you don't hear about the Canadian Incontinence Foundation ever, do we? We don't. You hear about heart and stroke, and they do great work, but you don't hear about these things. You kind of hear about falls, vision impairment, certainly cognitive impairment, malnutrition, and these things are just as common as the diseases. But in many ways, they're worse. They also increase with age, so the older you are, the more likely you are to have multiple geriatric syndromes. But here's the thing. This is an American study, and they looked at over 11,000 people in the community who were over 65. And they said, how does geriatric syndromes relate to disability versus diseases relating to disability? And I'm just going to highlight, if you have 2 or more geriatric conditions, you are more likely to be disabled than if you've had a stroke. Right? So these geriatric syndromes, these general signs and symptoms that we kind of slough off, they're not trivial. They're really important. And like I said, the data do not tell you what happens to individuals. But this is a very good example, using some of these common conditions. COPD, heart failure, falls. At the center is impaired cognition, because if you have impaired cognition, you have trouble taking your puffers for your lungs. And if you don't take your puffers, you have relapses and you end up in the emergency. People who have impaired cognition can't take their 6 heart pills and weigh themselves and eat the right foods, so they end up in hospital with heart failure. Cognitive impairment is a risk factor for falls. And it's not just that people make poor judgment decisions. Dementia affects the whole brain, and part of the brain is to coordinate how you walk. The relationship goes both ways. People with really severe lung disease are more likely to have dementia. People with heart failure are more likely to have dementia, right? The heart's not pumping blood, the brain gets damaged over time. People who fall end up in hospital, they get delirium, they get this confusional state, some of whom do not recover. Throw in diabetes, which always comes with lots of pills. And you have disability, you have incontinence. You know, heart failure is interesting. We give people diuretics so that they get rid of all that fluid. What does a diuretic do to someone who's got an irritable bladder? They have to go pee all the time. So you're running to the bathroom, you fall. All of these things are interrelated. They all come with anxiety and depression, all of these things. They come with multiple pills. They come with other comorbidities. We haven't talked about arthritis and thyroid disease, but they're there too. The caregivers have to deal with this, and it's hard, and they get stressed, and they get sick. And that uses a lot of resources. It's the same person as all of these things going on. And this is something that we call frailty. When you have so many things wrong with you that it doesn't take much to upset the apple cart. And that's a lot of what geriatrics is about, is managing this thing called frailty. Now, if you had all 240 geriatricians in Canada in a room, none of them would agree on a single definition of frailty, but they all agree that there's something about that person because they have all of this accumulated stuff, geriatric syndromes, disabilities, and diseases, such that they're vulnerable. So if they trip on the sidewalk or I give them the wrong medication, they will have a higher risk of side effects or a bad outcome. And that means disability, falls, ending up in the hospital, nursing homes, caregiver stress, and death. Now, does anyone know who this person is?
I can't remember her name, but she's the first documented case of a person with dementia.
That's right. Anyone know how old she is in this picture? She's 52. And the point is, it's not because you're older that you're frail. You can be young and frail. But most people who are frail tend to be older. But we can't forget these people who have perhaps younger onset dementia. So Ken Rockwood is a geriatrician in Nova Scotia, and he's got a nifty idea. Is basically the more things wrong with you, the more likely you are frail. And a lot of people don't like this model, but it works. Right? It works in mice, and it works in humans. And basically what they did, rather than using clever stats and looking at this whole list of things and trying to pick up 3 or 4 that are the biggest problem, he said, let's just count them and see what happens. And the more things wrong with you, the more likely you are to die. And in fact, if you hit about 60% of any list, it's incompatible with life. And that happens in humans and in animals too. So there's something fundamental about wear and tear. So what do we do about these frail people? Well, that's what geriatricians do. We work in teams, and we take a lot of time. And the whole idea is, you've seen that list of items, the 70 items. Well, there's more, but we go through the whole thing. We go through the medical, the social, the economic, the caregiver situation, and we try to look at the person's deficits and the person's strengths. And then we ask the person, what's important for you? So we collect a lot of information, we develop a plan, because there's never just one thing. And it has to be tailored to your overall level of fitness. So a very fit 90-year-old should be a perfect candidate for heart surgery, but a very frail 70-year-old shouldn't. And so when we have a sense of how frail they are, we can also decide what's appropriate therapies and what's not. A cholesterol pill, you should go into long-term care homes and look at all these people with advanced dementia who are on cholesterol-lowering pills to prevent a stroke in 10 years. It doesn't make sense, right? We like to identify stressors. So think of Ronald Reagan. He had Alzheimer's disease for about 20 years. He died at home. He avoided hospitalization. And that's because, yeah, money is important, but he was well surrounded and any potential stressor was taken care of. Look at another person who might be perhaps less frail, but they might have not enough money to pay for their meds or go to the physician's office, or they might have poor educational status. They don't understand how to read labels that tell you don't eat too much salt, and they're always in the emergency room. And so those are things that maybe are beyond that person's degree of frailty, but they're very important. The interaction is such that they run into trouble. So we want to reduce risk by managing the frailty and managing this person's stressors so that we make sure that nothing bad happens to them. And in the right person, comprehensive geriatric assessment is a good thing. Live longer, stay at home longer, saves money for the healthcare system, fewer falls, better cognition. So it's a good thing. But a 90-year-old person who's completely independent and golfs and drives his or her own car does not need to see me. So we have to be a bit more clever. Right? We can't spend 2 hours with everyone. So clearly one of the ingredients in solving some of the healthcare issues is this thing called the comprehensive geriatric assessment, because it works. But the question is on whom? So I like this slide because it's ridiculous. And this is the Ontario's Chronic Disease Management Framework. And that doesn't tell you anything, really. It does tell you a few things. We want to be proactive, right? Which means let's not wait till you end up in the emergency. Let's try to pick up trouble before it gets worse, which is good. The patients are here, and they're also here. So that's, from my engineering perspective, you can't have patients in multiple areas. That's hard to fathom. And it doesn't tell you who does what. Doctor, nurse practitioner, social worker, psychologist, psychiatrist. It doesn't tell you who does what job and to whom. And again, it's that question. Do you do comprehensive assessments on everyone? No. So how do you target? So you have to be a little bit more thoughtful about this framework, right? So one of the key things is patients and their partners need to be involved in their own care. And we'll talk about that a little bit more. It's not do as the doctor says. That's too paternalistic and it doesn't work. People should get the care they need, not more and not less. Right? I'm a fairly young person. If I stub my toe or I get a cut, I need stitches. I don't need a comprehensive assessment. If I'm 85 years old and I'm forgetful and I've had a few falls, different thing. It should be anchored in primary care. You should be able to go to your family doctor's offices and get this arranged. And as you saw, these patients are far too complicated for the competences of one single provider. A doctor can't do all of this stuff, a nurse can't do all of this stuff, a pharmacist can't do all of it. Right? Some people need input from many, many other providers. And so then how do we coordinate this? How do we assign jobs? How do we get these guys talking together so that it's in your best interest? So we have to start with risk stratification, right? Most people, regardless of age, are pretty well, so they don't need anything complicated. Some people are a little bit more complex, but they can still be dealt with, say, in a community health center or in a family health team. The really complicated ones need the specialist. But it's important that these not be siloed, right? I put those arrows there on purpose. All of these guys have to talk to one another because you might be low risk at this month and maybe in 2 years you have a heart attack and oops, you're higher risk. And then we stabilize you, you go back down. Oh no, the heart attack led to a stroke and now you have dementia, so you need a specialist. And once the specialist has sorted things out, you'll go back down. So this is actually a dynamic thing. Let's talk about heart failure. And I won't go through all of this stuff, but in cardiology, the typical clinical trial is in 65-year-old white men. They're not high risk. The typical heart failure person in Ontario is a 79, 80-year-old woman. So this study was interesting because they actually said, let's look at frailty. So this is a heart failure clinic, which has a nurse and a pharmacist and a physician. But they said, let's look at our clients and stratify them based on how frail they are and see who benefits the most. And the interesting thing is, those who are frail benefit the most. And you save more money in the frail, right? Bad things are more likely to happen to the frail, so if you spend more time on them, you'll have a bigger bang for your buck. So it actually saves money to spend more medicine time on frail people. Those who are young and not frail, they're going to do fine anyway. So you got a target, right? We have something about the frail means we need to figure out who they are. So there's ways to do it, and that's where the academics kind of fall apart if they don't actually go talk to family doctors. There are family health teams and community health centers, but in my region, 70% of the docs are solo. They don't have time to spend too much time, because they just don't. They don't have that time. So is there a quick and dirty screen that would say, you know what, there's something up, you need a bit more of a closer look? In a family health team, you might go straight to screening in terms of risk stratification. I'll explain what that means. So a quick screen and performance measure, right? Can I do something very quick that tells me there's something wrong or there's something, everything's fine? And it's kind of looking at a car, right? A car like that's not going to run well. You don't know why, you haven't gone under the hood. There are multiple deficits, like Ken Rockwood's Frailty model. But if I turn on the car, it's not going to go very well. So, not that people are cars, but the whole idea is that if the person's system runs more slowly, then there's something wrong. I haven't figured out what's wrong yet, but there's something wrong. And it turns out that something as simple as how fast you walk is extremely powerful as a predictor. So both men, both women, again, these are some of the references, but if you walk less than 1.2 meters per second, it doesn't take a lot of equipment, 2 pieces of tape 5 meters apart and a stopwatch. Someone who can't make that distance fast enough needs a closer look. The other neat one is grip strength. So how hard can you squeeze a device that measures weight, the strength of your grip? And that makes sense, right? We see some seniors, their muscles have gotten a little bit more shrunken, right? And their strength isn't there. And so grip strength is also a very powerful predictor. So if you don't have time as a family physician or a nurse practitioner to do a comprehensive assessment, you can still do a gait velocity or a grip strength or both and say, oh, there's something up here, I'm going to refer. In Waterloo, we use something called the assessment urgency algorithm in some family health teams. So I won't spend too much time other than to say that it was essentially a project that was aiming to look at seniors initially in the emergency, and so they asked family doctors and geriatric nurses in the emergency, if you were to design a 25-minute tool, what should be in that tool? So they designed a tool, and they validated it in about almost 900 patients. But the emergency doc said, you can't spend 25 minutes. Can you be quicker? And so they came up with a 1-minute thing. And you can get it on your BlackBerry or your iPhone or your Samsung. It's essentially a decision tree. So most of the time we ask 10 questions. And then you count the score and then we make a decision. But this is a decision tree. So the highest risk people, you only need to ask 2 questions. And these are some of the domains. Self-reliance means, does this person need help with their daily activities, yes or no? And if we just follow the logic, if they do have problems with self-reliance, is their family caregiver overwhelmed? And if yes, they're high risk. It has nothing to do with the diagnosis. If you can't look after your own affairs and the person who's trying to help you can't cope anymore, that's a problem. So there's self-rated health in there, there's shortness of breath, there's a sudden change in your health. The actual questions are a little bit more detailed. Mood is in there, and hygiene. And this is a very efficient thing. It takes on average about a minute to do. And what it does is it makes things a little bit smarter in terms of risk stratification, right? Again, you can't screen everyone. You can't do a comprehensive assessment on everyone. But if you start making the numbers more manageable, then it gets easier to do. This is in the emergency room. And basically, what it predicts is those who need a geriatrician assessment. If they get hospitalized, if they get admitted to the hospital, it also predicts those who end up stuck in hospital, which the government really hates. It costs money. And it's not the person's fault that they got stuck in hospital. The reason is that they didn't think about looking for risk, and they sort of waited 2 weeks, and then they figured out that, why is this person not going home? You can't walk because you didn't exercise. Don't get me going.
Yeah.
So, again, you don't want to assess everyone, and this just shows how the tool performs if you send somebody home from the emergency. The numbers are a lot more manageable. You end up only having 24% of people at really high risk who need to see a geriatrician this week. It also shows that there's a lot of people going home from the emergency who have some degree of risk, right? So how do we fix primary care? We've done some work in primary care itself. And it's even more interesting because the good news is that these people are not in the emergency, they just show up at the family doctor and we screen about 500. Look how manageable those numbers are, right? So it's a useful instrument that way because it really separates the really problematic high-risk people from those who are lower risk. The interesting thing that happens, while the tool took a minute, the docs were a little bit annoyed because then the patients wanted to have a conversation.
Pesky patients.
God forbid. So, comprehensive assessment is important. Case finding and risk stratification is also important. We want to be rational. It's not to save money. We don't want to waste your time. We don't want to waste our time. We want to make sure that we identify people who need an intense intervention and we give a less intense intervention to someone who doesn't need it, who needs less. So that conversation question is interesting because the docs were annoyed because that delayed things, but the nurses loved it because they were having a conversation with the patient. So the next question is, who needs to do what? And so in Quebec, there was a very interesting study where they looked at 37 primary care practices, almost 1,500 patients, and they did a review of the literature to identify quality indicators for chronic illnesses and acute problems, so sudden problems. So they picked diabetes and coronary artery disease, so people who have had angina or heart attacks. And then they picked cold, bladder infection, diarrhea, back pain, sore throat, bronchitis. So run-of-the-mill acute primary care problems and run-of-the-mill acute chronic primary care problems. And they looked at how well these studies met quality indicators. And then they decide, then the next question was, what is it about a practice that does quality care for these conditions? So the way you pay a family doctor, if you give them a salary, you get better quality of care. If there's a specialist in the family doctor's office on site, you get better quality care. If you have, I don't like that term, allied health professionals, but if you have nurses and social workers and pharmacists and other professionals, you get better quality care. If you spend half an hour instead of 10 minutes, you get better quality care. And, I know it. That's the engineer in me sort of would have predicted that. And if you participate in regular education, you get better quality care. Again, it's funny because this is self-evident, I think, but we had to do studies to prove it. So, another ingredient. You want different professions in primary care, including specialists, which is important because you know where all geriatricians hang out? In hospitals. You know where primary care is not in the hospital. So cardiologists, they hang out in hospitals. They're not in the family doctor's office. So that's a structural problem. And relationships matter. Being on site is more important than being at the end of the phone. Being at the phone is better than the way it is now, but There are some family doctors who graduate from medical school who've never really spent much time in a hospital. So they don't know their specialists. That's a problem. All right, we have 3 ingredients. What else? Engaging the patient in self-care. Again, how crazy is that? So the traditional approach is, here's your prescription, do what I tell you. Well, sometimes it's take your antibiotics, because if you don't, your pneumonia will get worse and you'll die. So that's, that's fairly straightforward. But for a chronic illness, you're going to have this for life. So we have to make sure that you understand as much as you can about your chronic illness. And again, I'll take heart failure. Heart failure care right now, 5 or 6 pills just for the heart failure, and they're all appropriate. You have to weigh yourself, because if you start to accumulate fluid in your chest, your weight's going to go up. And so you need to weigh yourself and say, uh-oh, I've put on 2 pounds this week, I need to do something about it. You need to eat low-salt food, so we have to teach you how to do that. You have to recognize your own symptoms. Not everyone gets the same symptoms. And then you have to know what to do, i.e. don't go to the emerge all the time. So this is quite a significant ask for the patient. And you know what? It's doable. Because heart failure clinics cut down readmissions by 50%, mainly because we do that. So I'll skip that. Oh no, let me go back here. One of the other things we want to do, so not only engaging in self-care, we often wait for the doctor to make a pronouncement. Right? But if you have a chronic illness and you need rehab, do you have to wait for the doctor? The doctor probably doesn't know how to recognize someone who needs rehab. Doctors certainly don't know how to prescribe nutritional advice. Doctors do not know how to help you cope with chronic illness. Doctors do not know how to help you figure out how to get Rogers to sign over the account that your dementing spouse has with the phone so that you can actually pay it. You need a lot of help. And one of the things that we've done in Waterloo Wellington, so we've used this thing called the assessment urgency algorithm that I described. And the neat thing is that tool is in use all across home care in Ontario. And in Ontario, we collect this instrument called the RIHC, which is a comprehensive set of information. And so what we did is we said, what does someone look like by AUA score? And this is home care, so they're a bit sicker. But if you're low risk, you're still not perfectly healthy at that age, right? Most people's cognition is fine, most people's function is fine, but 14% have depressive symptoms that are potentially important. Half of people have pain, right? And incontinence, 25%. So they may be low risk and the doctor may have nothing to say, but you still have needs. So what do? How do we refer you to services? And obviously the frailer, the more complex you are, the more these things are important. And so what we've done is we sat down with a bunch of professionals from different disciplines and we said, what referrals would be appropriate for someone who looks like this? And we've programmed it into something called CareDove, which is basically our regional website that you can access to get support services in the community. And we've built in the recommended services for someone who's at low risk, medium risk, and high risk. And so you can work with your, say, nurse practitioner, whoever in the family doctor's office. You know what, you're medium risk, what kind of things do you need? You click on that and it will show you a page which has services that would be suggested for someone with those needs. And with that website, the next thing you will be able to do is basically make the referral right there.
You want to give us a little detail about the website?
Yeah, I can send you it's called caredove.com.
All one word?
Yeah, CareDove. Yeah. And you put in your postal code and it will say Meals on Wheels nearest to you, or exercise program. So Arlene basically said, let's put everything on one site to make it easy to navigate. And what we've done on top of that is superimpose the risk stratification. So you may still need to see the doctor because of the pain, but the nurse can get the ball rolling. You don't have to wait for the doctor to make the pronouncement. And there are also patient passports that my PhD student helped develop, basically. You know, if you're at low risk. There's some chronic disease education programs, recreation programs for the low risk. Medium risk, you might need community support services. You might want to talk to your pharmacist because you've got lots of pills. High risk, memory clinics, comprehensive geriatric assessment. And so we share that with the patients as well. So that's another thing you can do. The other thing that we often don't do, because we provide care in episodes of care, we don't think of the future. So chronic illnesses like heart failure or COPD relapse, remit, and over time people deteriorate. It's inevitable. And so that's the nature of chronic illness. And if you think about it in terms of risk, you might start off low risk, oops, heart failure admission, stabilize it, you're better. But as you get older and frailer, the risk starts to be more in the medium range, starts to pop up in the high risk. You stabilize things, eventually you relapse and remit. And we have to recognize that, because often I speak to some of my cardiology colleagues who don't do heart failure management, and they say, I follow this patient really closely, I see them every 3 months. Well, that's great if your disease has an exacerbation every 3 months, but most diseases will deteriorate on their own time. So you have to think of that. If your disease gets worse in 2 months, what are you going to do? Well, the default is call the cardiologist. He'll say, I can't see you till next month. Go to emerge. Right? But in a true heart failure clinic, you'll speak to a nurse who can talk to you on the phone, bring you in if you need to be seen, figure things out right then and there. We have to do it that way. Anticipatory guidance. We have to think ahead. So, another ingredient, self-care. And we have to think about appropriate interventions. We have to be proactive with our referrals. And we have to think ahead. Right? We just did a study on quality of care in patients with dementia, and we asked people about various aspects of the care. And everyone was really gung-ho about blood tests and CAT scans, which is fine. Then we asked about advanced care planning, and that one kind of was ranked lower by specialists and family docs. And they said, well, we don't want to talk about that because it takes away hope. That's true. But if you wait too long, the dementia gets worse. And you can't engage the person anymore in terms of figure out what they want. Right? It may be an unpleasant discussion, although in my experience, and the literature bears that out, people want to talk about it. You need anything else? Let's talk a bit about nursing homes. How are we doing? Not too bad. All right. So we're wrapping up. We've got 10 slides to go. This is some of the more recent work that we've done. I've always been interested in long-term care, and I've always been interested in heart disease. And long-term care is one of the spots where heart failure is tough to manage. There's a lot of it, and despite what you read in the Toronto Star, most people in nursing homes try their damnedest, and with very little. It's really hard. They're starting to do dialysis in nursing homes, right? Imagine that. So we said, okay, how are we going to translate heart failure guidelines in a way that they can actually do this? Because they're working 24 hours a day. We can't ask them to work 28 hours a day. So how do we do this? So we went in there and we did a lot of interviews and discussions and teaching with docs and nurses, but also personal support workers, pharmacists, directors of care, and patients. The patients were very funny because they noticed, good Lord, no one's talking with one another. But they were too shy to bother them. But big things, communication gaps, people don't talk with one another very efficiently. And in many cases, they don't know what heart failure was. Someone said, isn't heart failure what happens if you're constipated? Right? This is a health provider. Yes, there are workload issues, there are health system factors. There's no x-ray devices in long-term care, but even if you had them, because people aren't familiar with the disease and they don't communicate, you're still not going to fix the problem. And so what we did is again with Veronique Bosgart, we developed this intervention. And because I'm affiliated with McMaster, we had to come up with a really fancy acronym, so I apologize for that. But all we're doing is addressing knowledge, and we're addressing interprofessional collaboration. One of our grant proposals got refused, and one of the comments was, I fail to see how improving knowledge and communication would improve outcomes for residents. Anyway, so 4 phases. We start by very simple education that is tailored to the needs and educational and skills of the provider. But it wasn't that basic. I mean, the PSWs, for example, that people never really take seriously, they love this stuff. And they really got into it, and they had a lot of questions to ask. So we gave this to everyone on the units. Those who were the keeners, and those who were flagged by their staff as being really good, we brought them together to hold a workshop. We gave them more heart failure education, more in-depth education, but we said, all right, you guys, we know that communication is really important. And from our previous work, there's 5 episodes during the life of that resident that are critical. When they get admitted, when the doctor shows up, when you guys change shifts, that's where a lot of miscommunication happens. Monitoring weights. So I talked about heart failure. It's an interesting disease because the first thing you notice when someone's heart failure gets worse is they're starting to accumulate fluid. Their weight will change. It'll change the week or 2 weeks before they actually feel short of breath. So that's why we have to weigh them frequently. Because when the weight goes up by 2 pounds in a week, it's not food, it's fluid. And then ad hoc, which basically means your day is going along smoothly and all of a sudden Mrs. Smith is not looking very well and we have to interrupt what we're doing. How are we going to do that? And we basically said these are the things you have to figure out on your own. You know, what are you doing now? Does it work? If it doesn't work, how would you change it? And we spent the whole day with the teams coming up with these protocols. We decided who's going to implement them, how are you going to implement them, who's going to monitor. And then we bring in the doctors. We bring in the doctors, we start teaching them. And while we're teaching them, we're practicing these communication protocols, and we're practicing bedside assessment with the nurses and the PSW. And so finally, when the doctors had their training, we say, come and see what your team has done. And we get the team to pick a resident, practice their assessment, and then they present their assessment to the doctors, and that's really fun because the doctor's jaw just drops. And the first couple of residents that we assessed by the team, they had heart failure diagnosed for the first time ever. The doctors had no idea. No one had any idea. It wasn't documented. And we do this with me and Veronique, who's a nurse at the bedside. We basically go back to med school and we do some bedside teaching with them. So we did this pilot study in 2 units in 2 nursing homes because Heart and Stroke felt sorry for us, and they gave us a bit of money, even though the reviewer said, I can't believe this will work. They still gave us money to do it. And we did a lot of interviews and measured knowledge and interprofessional communication. And what happened is, it's really nice doing this kind of research because we basically had the teams give us feedback. And in many ways, they figure out how they're going to run this. So they identify their members, they identify their champions, they figure out the communication processes, they pick the residents that they wanted to assess, and they were very enthusiastic. And the beauty about heart failure is you diagnose it, you give them some diuretics, and in 2 days they're better. You get immediate gratification, so they get that feedback. And so basically, more knowledge, better interprofessional collaboration, and they were actually picking up heart failure. We hadn't anticipated the last one because it's a small scale study, but the first patients we saw, we picked it up. And so one personal support worker basically, interviews are great. And this intervention has really trained us. It helps us think in a bigger perspective. And I think that's one of the really neat things. So all the time when someone has behavioral issues in long-term care, we think, oh, it's dementia. But they basically said, why are they confused at night? Doesn't make sense. Could it be something else? So they thought heart failure, but they also thought it could be pneumonia, could be some other illness. So they were now starting to think big. And they realized that I can do this. And they thought it was extremely empowering. To me, that was the best part, is the physicians went from, I don't talk to anyone but the nurse, to, I'm not going to round without the PSW. And the PSWs have a mortal fear of physicians. And now they're basically leading the rounds. And they say, Doc, you come, I got a few patients for you to see. So it's completely changed the power dynamic. So, you can add knowledge. And our intervention basically had specialists embedded in the nursing home, and we're doing that in primary care as well. And interprofessional training. Now, that question always comes up. We don't have a family health team. What are you going to do? Family health teams are nice. Community health centers are nice. They're funded to have all of this staff. Well, some guys in the States thought about this. You've got the website there. This is a program of research that's been going on now since the mid-2000s. And essentially they developed what turns out these 7 elements. They've actually put them into practice, where they essentially have nurses and social workers who support patients assigned to a certain region of family doctors. And they will see them in their home if need be. And we will do their assessment. The patients are identified, they're risk stratified as being high risk. It's the US, so they use insurance data. We can use our AUA if we wanted to, it doesn't really matter. They pick the high risk, they go to their house, do an assessment, they bring this back to the team, which includes all of these professionals, and they bring in the family doctor, and they come up with the patient with a plan. And then they stick with that person. Even when they go to hospital, they'll go to the hospital with them and make sure that the information goes with them. They've got evidence-based guidelines. They have an electronic medical record that is seamless and shared by everyone. And they don't wait for things to happen. They check up, right? And they promote self-care. And because they're based in home care, they can connect the person to all the services that they need. And there's been a number of randomized trials with 3 years of follow-up. The interesting thing is the first year you see better patient outcomes, but the costs aren't down yet. And the reason seems to be that all of these professionals who never worked together are trying to feel each other out and figure out who does what. It's that interprofessional thing. But year 2 and year 3, the costs go down. So basically, I think that these are the ingredients we need to shift the healthcare system, right? We've designed a healthcare system around doctors and hospitals that does not suit the needs of the 2016 patient. We have to basically flip things over. The hospital's got to be the last resort. And we have to be upfront and in primary care. And I don't think it needs more spending, because what we see is when we get people collaborating and learning about certain diseases and being more efficient, we actually save money. Not that I condone healthcare cuts, but healthcare cuts or more spending is not going to fix this. We have to fix fairly fundamental and structural things. So I will stop, and any questions? I went a bit longer than I wanted. Yeah.
I appreciated your acknowledging the funding models for particularly physicians as having a role, as playing a role in this. And I'm wondering what your position is on really finding a way to bring physicians into team practices and on a salaried basis, as opposed to, I like all of those components, but it's, I still think an impediment is the single fee-for-practice physician. It's only one of the problems, but it's a pretty significant one.
And so there's a number of issues there. Right now, there are some services, especially the technical ones, where the billings come from the poking and the prodding and the taking, be careful, medical imaging, because you get paid to look at pictures. And if you look at a hospital, there's a bunch of, say, radiologists, and there's a certain volume of x-rays. If it's cardiologists, there's a certain volume of ultrasounds and ECGs. Someone has to read those. And there's a fee for each of those, and so they share that, and that's a bulk of their billings come from that. Cardiac catheterization. When you have a heart attack, it's put in a stent. Right? You get a lot of money for that. It's technical, but you get a lot of money for that. And what happens is sometimes you want to bring in a new recruit who's got this new procedural skill, and to get them paid, you kind of have to cut into that pool of readings and billings. And then sometimes they don't want to share. So that's a problem. The second thing is Cancer Care Ontario, when they started to centralize cancer care, they gave the cancer specialists a flat salary, thinking that this is going to allow them to spend more time. Well, what happened is in some areas they would only see 5 or 6 new patients a week. And so they actually did less. And then what they did with geriatricians is, I think, interesting and clever. So geriatricians, traditionally the fees were like any other specialist, but because you spend 2 hours, you make a lot less. So they've changed the fees, but the government said, let's be a little smart here. If I work with an interprofessional team and I teach, I get a bonus. And the team has to write a letter to the ministry saying that I did that. If I work with the healthcare system and I work with the LIN and I talk to them about service development, they can write a letter and I get a bonus. And in a sense, it's sort of a mixed model where I have the incentive, if I want to see more patients and bill more, I can. But if I want to spend more time and do some thinking and teaching, I don't get penalized. And the bonus that this brings to the people who run the healthcare system is they can figure out where they want their teams to go. And if the team is now built into primary care, we can either do that GRACE model or family health teams. The doctors are going to follow the money, sad to say. But you can design a billing structure that can suit the needs of people with chronic disease. Now, geriatrics is fine. For cardiology, they actually got rid of the fee codes that would give bonuses to cardiologists who did heart failure care. Partly was there was no accountability mechanism, but the problem is heart failure is very common, and now you've taken the incentive for the guys who mean well to actually do it. So there are ways to do it, but this is a big issue. And in the UK, most specialists are on a salary anyway. And the third most common specialty is geriatrics. They have 1,300 geriatricians in the UK because they took the money thing out of it. Sadly, it's an issue, but it's fixable. They have to be clever.